Hi. I want to talk to you this evening a little bit about the Argentinian flag sign. This is going to be a live stream, so I'll probably look back later and try and edit it, see if the audio is working or not working. But in any case, in terms of the Argentinian flag sign, the reason I want to talk about this today is because it is something that's important to be able to deal with it. In my practice, it doesn't come up that often or it doesn't happen that often, but it is something that's important to be able to know how to handle. So, what is the Argentinian flag sign? It really represents a radial tear in the anterior lens capsule whenever you're trying to do the capsulorhexis. So it's called the Argentinian flag sign because usually it's in a white cataract. You've stained the capsule with blue dye. And then as you're starting the capsulorhexis, the capsule can split or the capsule can run off, and you have this white stripe in the middle of the trypan blue, which reminded somebody at some point in time of the Argentinian flag sign. I actually don't know who coined the term or who first called it that. That would be interesting to research and look up, and maybe one of you knows it and can comment below. So I want to show a video a case that I had a few weeks ago, maybe even just in the last few weeks. And this was interesting because it was a patient who I hadn't indicated that I needed to use blue dye at the time of when I consented the patient just a week or two before surgery. But when my scrub tech was draping the eye, said you may need to use blue dye for this case, which was somewhat puzzling. And then I asked the patient on the table, "What's how's your vision?" And he said it's gotten significantly worse over the last week. And so when I looked at him under the microscope, this is what I saw. You can see that there's this white, the anterior capsule is the cortical material underneath the anterior capsule is already turning white. So this is actually a good point here. If someone's cataract develops quickly, or they give you a history of somewhat subacute onset of vision loss, that's cortical material has just liquefied, and a patient like that, an eye like that, is you're more likely to have that bag be under pressure and more likely to result in the Argentinian flag sign. In my experience, most white cataracts, the bag is not under pressure. But in these patients who, when they're relatively young and they've developed a cataract in a short period of time, then be prepared for to have a bag that's under pressure. So I'm going to start playing this video, and then we'll just talk through this case as it happens. So I'm proceeding with surgery. That's probably my preservative-free lidocaine, um, and maybe some epinephrine here to try and keep the pupil open. I'll probably put in some. I'll probably use capsular dye now. I'm going to inject an air bubble first, and then use capsular dye after that. And you know, in retrospect, I probably should have decompressed this capsular bag. Whenever you're worried about the capsular bag being under tension, whenever I'm worried about the capsular bag being under tension, I'll usually go in before I use a cystitome. I'll use a 25 gauge needle, puncture the anterior capsule, and aspirate some of the cortical material. And that decreases the tension, makes it less likely you're going to get an Argentinian flag sign. And as I've probably already uh, hinted at here, I didn't do that in this case. So once I've injected, you can see we've got a pretty good stain here. I like to remove the capsular dye just by injecting viscose into the anterior chamber. I'll use 0.12 forceps and a keratome blade to make my main incision. And then I'm gonna go in directly with the cystitome. And this is the part where you really just need to pay attention to what's happening here. So I'll go in with a cystitome, and right away there's a plume of cortical material that comes out. And you can see right there to the right of my cystitome needle, the capsulorhexis just kind of, that opening just kind of extended. and then I extended both to the right and to the left. And so that tells me that capsule is under tension. And already here I'm starting to feel a little bit anxious that this may just, split open and open up on me. Nonetheless, we persevere, and I went in with my Etradas here, or capsulorhexis forceps, and I know that this capsule can extend at any point in time. So I'm making every effort to make a very small capsulorhexis here, but you can see it's already starting to go out. And so I'm trying to pull it back in, making a small capsulorhexis, and I'm trying to decompress with my capsulorhexis forceps. At this point in time, it's probably may still have been helpful to go in there and try and aspirate out some of that material in the bag, but I didn't do that. So in any case, I just continue to do my capsulorhexis. I'm trying to keep it as small as possible. It keeps wanting to go out. You can see there as I'm pulling centrally, it keeps wanting to go out. But now I'm pretty happy. I think the capsulorhexis is too small, so I am going to try and make it a little bit bigger than where I left it. And you want to be careful here that capsular flap doesn't come out through the main wound and cause a capsular tear that way. But I'm just going to continue to extend and enlarge this capsulorhexis, knowing that I can just pull it centrally at any point in time and complete the rhexis. So what I did there is I started out with a very small capsulorhexis, and as I came around, I just enlarged and enlarged and enlarged that capsulorhexis until I got a pretty decent sized rhexis. Now, because it's liquefied typically within the last week or two, there's not going to be much adhesion here, and I still will hydrodissect. And here we got the lens nucleus prolapsed, and there definitely is some volume to this lens. So that's probably the most interesting part of this case. And just whenever you think, I guess the take home here is if the cataract developed rather quickly, or the patient's relatively young, you'd probably want to decompress the capsular bag before starting the capsulorhexis. So here we're just, you can see there's a lot of cortical material there that I just suck up with the phaco. I'm going to probably speed this up just a little bit. So now we're at 2x speed. I don't know if I really got a crack there or not, maybe a partial crack, but I do have what looks like a quadrant there. And in these cases, I'm just going to take what I can get. And so we've got a quadrant out, and it looks like I did get a crack. So we're getting the second quadrant out here. And once again, this is 2x speed here. Third quadrant, and then there's still a fourth quadrant that's in there, which I use my second instrument to push centrally. I don't remember anything else about this case really being too abnormal. And you can see there's just maybe some cortical material there, not too much, nothing that's too significant. I probably will go in with IA here, yes. So I'm going with IA, just cleaning up that cortical material. And then we're going ahead and just removing the rest of that cortical material here. And then we'll place viscoelastic to fill the capsular bag, and then I'm going to place the IOL. This is my capsule polisher. Probably don't need to do too much capsule polishing here. And then I'll do this little maneuver here, Pro-Visc to the right and left of the wound, just in case there's any lens material that's still hiding in the anterior chamber angle. Oh yeah, this was a toric lens. That's why this case is longer. So this is a toric lens. This patient had a mature cataract. Nonetheless, he had some corneal astigmatism. And so what I'm doing here, that was a tonometer, because I'm going to use the Aura intraoperative aberrometry to help me align the toric axis. So you can see the intraoperative aberrometer here, and it tells me which axis to go at. And I'm just going to remove viscoelastic and try and align that IOL with that axis, and then the intraoperative aberrometer, in this case it's the aura, will let me know how much residual sil is there, and I can rotate the IOL clockwise or counterclockwise to minimize any residual astigmatism that may be present. So after I'm happy with the cleanup and with the IOL axis, I'll hydrate the wounds, look at that reticle and look at the aura axis. I'm pretty happy with that. It's pretty well aligned with what aura is telling me to do. And of course, in the toric, you have the toric markers, the 3 little dots on each side of the IOL. Once I'm happy with the pressure, I'll look at the residual sil that's present. And then, here I'm actually not looking through the scope. I'm looking at the aura machine, and I'm just looking at how much residual sil, whether it maybe telling me to rotate clockwise or counterclockwise, and I'll just see if if its recommendation is making sense with what I had preoperatively. And if it isn't, and based on that, I won't always follow the recommendations of the aura. I'll look at my preoperative sil. It looks like here I'm happy with where it's at, and that's really the end of the case. Check the wounds, make sure they're watertight. I do want to show here, I think this is it, the previous case that I'd done of the showing the Argentinian flag sign. This is one of my YouTube videos, which you can find on my channel. This is from several years back, 14 years ago, so 2011. And this is what can happen in the Argentinian flag sign. This is also a young patient with an intermittent cataract. And you can see sometimes you can just get a split just like that with these capsules that are under tension. That video is on my YouTube channel. And let's see here. So that video is on my YouTube channel, as well as the management of that case are also on my YouTube channel. So thank you all for watching and your attention as far as the Argentinian flag sign. I'd love to know your thoughts and hear your thoughts on this, and whether you handle these any differently. And like I said, I'm not really used to live streaming too much, so hopefully the audio came through and the videos came through. And I'll check the quality here in a little bit. All right. Thank you all for your attention, and have a good evening.